Assalamu alaikum wa rahmatullah. Good evening, everyone. We are back with the Dubai Shoulder course, this time for a webinar. It's the second webinar in association with the Egyptian Arthroscopy Association, the EGAA. We really thank Dr. Adil Hamid, the president of the Egyptian Arthroscopy Association, for the cooperation to run this webinar. Today, our webinar is a bit different. We will talk this time and we will focus mainly on the surgical technique. We have 4 eminent shoulder surgeons tonight with us. They will talk about subject related to the rotator cuff repair. We'll start with our speaker, John David Werthel from Paris, France. John David is a well-known shoulder surgeon in Paris. He did his training in Paris with Dr. Philippe Hardy and Philippe Valenti, did some of his training with Pascal Boileau and the other big guys of shoulder surgery in France. Then he did a fellowship in Mayo Clinic with Bassem Al-Hassan. Then he's back and practicing now in Paris. John David will start with us and he will show his technique of how he is doing rotator cuff repair in a lateral decubitus position with a double row technique. Then our next speaker is Dr. Ahmed Saeed, who is the professor of orthopedic surgery at Ain Shams University in Egypt. He's the head of the arthroscopy and sports injury unit in Ain Shams University, and he will share with us his experience tonight with how he's doing double row repair arthroscopic in beach chair position. Then we'll move on to our eminent shoulder surgeon here in the Gulf area and United Arab Emirates, my friend Saeed Althani, the former president of the Emirates Orthopaedic Association and the president of the AO Trauma Education in the Gulf area. Saeed will show us how he is doing step by step, how he is repairing the subscapularis. Then finally, my friend, the Associate Professor of Orthopedic Surgery, Ahmed Hany from Ain Shams University, he will complete the subject by when exactly and how he is doing acromioplasty, his own technique of doing this, and how he is doing also AC joint excision. Welcome, everybody. So I'll start immediately with John David. John.
Okay. So thanks a lot for the introduction and thanks a lot for the invitation. So just a very short introduction. When we talk about rotator cuff repair, I think it's very important to have in mind the exact shape of the footprint and the insertion of the cuff. And it's important to know that the subscapularis inserts very close to the cartilage, to the humeral cartilage. It's the same thing for the supraspinatus, but for the infraspinatus, there is a few millimeters from the cartilage. There is this bare area that needs to be respected when we do our repairs. The dimensions of the repairs, of the insertions, they vary, of course, depending on the anatomical studies, and this we should have in mind also that in some studies, especially recent Japanese studies by Mochizuki, the footprint of the supraspinatus is actually much smaller than what we commonly represent on our drawings, and that often when we have a tear of the supraspinatus only, well, it's not only the supraspinatus because there is always a layer coming from the infraspinatus. Of course, you all know the indications for repair and the repairability, and you know that when the tear is too retracted, it's not a good idea to try and repair the tendon. You also know that this is a study from Dominic Meyer in Zurich, that the tendon length is a very important landmark for repairability. And we know that if the tendon has a greater length than 15 millimeters, then it's a good idea to repair it. But if the length is less than 15 millimeters, it should not be repaired because it will not work. Of course, you all know this fatty infiltration that has been described by Goutalier, and you know that if the fatty infiltration is greater than 3 or 4, there's no point in trying to repair the tendons because it's not going to work. And so we have all these factors. We also have factors that are depending on the patient and for which we cannot do much. Of course, diabetes, hyperlipemia, advanced age. We know that inflammatory arthritis also is going to affect the bone quality and it's going to affect the healing of the tendon. But we have also some factors that are related to our technique. So it's very important to have a nice technique when we repair the tendons. I like to do it in lateral decubitus because that's how I've been trained to do it with Philip Hardy. And it's very convenient for me to have a nice traction and to open the subacromial space. I always do this except for AC joint resections. When I only have to work on the acromioclavicular joint, I tend to put the patient in the mid-chair position. But for the rest, I like the lateral decubitus. We also know that we can improve the clarity of the visual field by adding some tranexamic acid inside the intravenous perfusion 10 minutes before the surgery, 1 gram. And we can also improve the clarity of the field by adding some epinephrine in the serum. And there was a study from a French team also showing clearly that the clarity of the field is directly related to the increase in blood pressure. So if your anesthesiologist tells you that it's not true, well, it has been proven, and they are responsible for part of our troubles in the operating room. And so the steps are very easy. I like to do always exactly the same steps. I like this drawing because I like to turn around the shoulder, just as like Laurent Lafosse told me. And so I have 12 steps, and it's always the 12 same steps with always the 12 same portals, because I get lost if I don't do it that way. So the first step is always to go posterior inside the A portal that I drew on this graph. And this is the posterior portal in the soft point. It helps you go inside the joint. And when you're inside the joint, you can do your intra-articular exploration. I always do an instrumental portal inside the tear, always, and it's always at the same position. I draw a line that follows the anterior border of the acromion, and I draw a line going around the shoulder coming from my A portal, and the intersection of those two lines is the B portal, and this B portal is going to go directly inside the tear. It's my anterolateral instrument portal. Then I do something on the biceps. In younger patients, I do it in odesis. In older patients, I tend to do it in otomy. If the subscapularis needs to be addressed, this is when I do it. And then I go and work on the subacromial space. To go in the subacromial space, I always start with the posterior portal. So I go in the A portal and I go posterior inside the subacromial space, and I debride the cuff. Once this is done, I always create a C portal, and the C portal is where my viewing portal is going to be. And that C portal, I do posterolateral, and I always stay on the same line. And this line, I go 2 finger breadths posterior to the B portal. And so this allows you to have nice triangulation and not to get tangled inside the shoulder. Then we need to add an extra portal to insert our suture anchors. That's the D portal. And then we do the repair. And first we do the repair with the medial row. I like to tie knots, and then I like to do a lateral row. I like to tie knots because I like those 2 rows to be completely independent. And so we're going to see the steps. I'm going to try and detail them. So this is a cuff, and you can see you're inside the intra-articular space, inside the glenohumeral space, and we're doing the lateral portal. I'm using a needle to identify that sweet spot that I showed you, and it is always at the intersection of the line going from the anterior border of the acromion and the posterior viewing portal. I like to start the debridement of the footprint at that step. And so we remove all the soft tissue because we know that it is important to have a nice contact between the repaired cuff and the bone, and so we don't want any interposition of remnant and soft tissue. Here the biceps didn't look too bad, but the patient was 72, so we decided to do the tenotomy. And then sometimes, like in this case, you see that the subscapularis is very difficult to see, especially when patients have a thick middle glenohumeral ligament like this one. And so I tend to cut it quite systematically in order to visualize clearly the upper border of the subscapularis to make sure that there is no tear of the subscapularis. If needed, I open the rotator interval and I identify the coracoid process, as you can see here. So here we can feel inside the interval the coracoid process, and we can see the coracoid process right here. And just underneath, we can see the upper border of the subscap. That is nice. Then we go back to the tear. And what I like to do is to position the vapor, the cautery, above my tear. So I'm sure that the instrument is inside the subacromial space. And then I switch to that subacromial space. I go in the subacromial space, and because I put my instrument there already, it's very easy to find. And the first step for me is to go and debride all the anterior and lateral part of the acromion in order to remove the AC ligament that goes down just like a curtain, and it opens the space. And I like to start with this without looking at the cuff at the beginning. So I start really looking at the limits of the acromion, preparing the acromion, the anterior part, the lateral part. I like to see the limits. Typically, you can see some ossifications and osteophyte, and this is what I'm going to take down at the acromioplasty in the end. And I like to go all the way medial to the AC joint. So it takes a little bit of time to expose clearly that acromion. Once the exposure of the acromion is obtained, what I like is I just move the camera, and I look downwards, and downwards you can see the tear. So the first step is to use a burr. I'm not too aggressive on that step because I don't want to remove too much cortical bone. I want it to stay cortical bone, but I like to freshen a little bit the footprint of the supraspinatus. Here there was no much preparation needed above the cuff because there was not too much synovial, but sometimes you need to remove all that synovial tissue, and you start preparing from that viewing portal. You can start preparing your lateral row by removing all the soft tissue, debriding all that lateral part of the humeral cortex. Once this is done, you switch your portals, and we go to our posterior lateral viewing portal, and you can see that we have a view above. We're looking at the cuff directly from above, and then we create our C portal, and our C portal is the portal that we're going to use as a parking lot portal, and also to position the anchors. I like to use also that portal that is coming from above to continue to prepare the lateral part of the humerus, because this helps preparing the insertion of the second anchor, of the second row anchors. You can see here that you have two layers of the tendon, and here we're starting to put the medial row anchor. So the first one is going to be anterior, and it is an all suture anchor, but I have no real preference for this. So this anchor has been positioned. We have the anchor that is in the bone, and then we're going to start and retrieve the sutures. So you have as many techniques as you have surgeons. Depending on the size of the tear, I put all sutures, or I only use 2 sutures of each anchor. Or sometimes I use tapes and sutures, but all the time what I try to do is to tie knots on the medial row, because as I told you before, I like my rows to be completely independent from one another, because I have seen some anchors pull out on the lateral row, and if you have no attachment on the medial row, then all your construct is gone, and I hate seeing that, especially in patients with osteoporosis. You know that the bone is not that thick, and I cannot trust the pull on the lateral row. So then we pass the sutures in the anterior part of the cuff. Here we're passing the posterior sutures in the posterior part of the cuff. We use a suture passer from any companies. We don't really care, and we remove the sutures. All the sutures are placed in the parking lot portal, and then we tie the knots. I like to do an Icke's knot and then to add some extra knots, but again, there's no technique that is better than any other. The idea is just to have some attachment at the medial part. What is quite important is to have the two sutures that are going anterior and posterior to be not too far from one another, because if you tie your knot, you're going to have a very big dog ear if you don't pay attention to that. And then we do the same thing posteriorly, and we tie our sutures. And then once the sutures are tied, we're going to take one of each and to do a very simple and classical suture bridge construct. And the idea is to have some bridging. So we take one blue and one white suture, and we're going to place them on an anterior lateral row suture. Again, nothing very complicated, very classical construct. We try to go a little bit lateral in order not to be too close to the footprint. And then we do the same thing posteriorly. We make sure that we do not over tension our construct when we place the second row anchor. And then we take the one anterior suture and the other posterior suture, and we're going to attach them similarly posteriorly this time. A nice trick can be to switch again to your posterior portal, viewing portal, and maybe sometimes you, especially in larger patients with large humerus, you can use your posterior lateral portal to insert your posterior anchor. This can help sometimes because sometimes the orientation of the anterior lateral portal is not good for both lateral sutures. And here you have the construct in the end, and it's stable. And what we do in the end always is the acromioplasty. And here again, nothing very complicated. So we have the limits that are very clearly defined. Of course, this is not real time. This is a little bit quicker. And the idea is not to be too aggressive on the acromioplasty, because it's the literature seems to say more and more that this acromioplasty is not something fundamental, something essential. But I still like to have a flat acromion at the end of the procedure and to recreate a nice subacromial space. If on the preoperative X-ray you see that your CSA, your critical shoulder angle, is very, very high, it can be an idea also to decrease it by performing a lateral acromioplasty. And this has been shown to be a nice thing, maybe to decrease the risk of re-rupture and to improve healing of your tear. So you see something very, very classical, nothing complicated in this patient. So thanks a lot for your attention, and thanks a lot again for the invitation.
Thank you very much, John David, for this very nice illustration. It's very clear videos, very clear message. So I will move on with the next speaker, Saeed Althani. Saeed, can you start sharing your screen? So Dr. Saeed Althani will talk tonight about how he repaired the subscapularis.
Okay. So when we talk about subscapularis, it's a tear that been first described by John Gregory Smith in 1834. It's about 100 years later, was also documented by Codman. And it wasn't interesting to the surgeon until 91, when Grover and Crushel talk about isolated rupture of the tendon of the subscapularis. So where's the anatomy, where what we hold around the subscapularis? You have to understand its relationship to the superior ligament, and also its contribution in the biceps stability, and also the relationship to the medial humeral joint. So the footprint is larger than the infraspinatus and the supraspinatus. If you do open surgery, if you do letter J, you know where how big is the footprint area for the subscapularis. So it's about almost from superior to inferior, about 2.5 centimeter, and take about 2 centimeter width. So it is not a single point, it is a broad spectrum insertion into the lesser tuberosity. How we diagnose? We diagnose with the clinical lift-off test, or belly press test, or bear hug. The multiple tests can be done to diagnose, but we need to look at the MRI and look at and dissect that MRI to see what we need to see. So if you look at this MRI and the A here, you can see the subscapularis there. You can see the lesser tuberosity, the bicipital groove, and you can identify the subscapularis tendon. Where here on the P, it's retracted, and also here it's very thin, maybe just as we call it, Purcell side tear, like for the supraspinatus, articular side tear, it's like the supraspinatus, and maybe just a small fibrous tissue that's holding, and you can see it is very flimsy tissue that's holding. This is, for me, it's almost near complete or complete tear. And just you're lucky that this tissue holding the subscapularis for you to ease your repair. So if you want to see more image and the different angle, we can see it here where the bulk is gone. So if you look carefully for your MRI, you will identify it. You can see the bulk here below the coracoid process of the subscapularis. Here is degenerative subscapularis. That can happen from disuse atrophy if the patient has been a long time on tear and neglected. So indication for surgery, painful shoulder with evidence of full thickness subscapularis tear or partial thickness tear, which is failed non-operative treatment, or if it is part of overall massive tear, traumatic tear, like supraspinatus and infraspinatus. And you know, it's very painful because with this tear, they get their biceps tendon dislocation, rotating the biceps, and that causes severe pain as well. So how we look at it? We look at the comma sign. This is the biceps tendon. Sorry, this is subscapularis here. That's where supposed to be the bicipital groove. And you can see this area, that's what we call it comma sign. And that's from retracted subscapularis. So how we classify? We can talk about the Lafosse classification, where it's type 1, 2, 3, 4, and 5. It depends on where is the tear. If it's the tear from the superior portion, it's type 1 and type 2. Then as it goes further, it's type 3 and 4 and 5 when it is completely detached. And in certain cases that can cause anterior subluxation or fatty infiltrations. So how we look at it arthroscopically, you can see here maybe it's a grade 1, and on the left side it's a grade 2. This is here grade 3, which is peeled at the top, and I think this is will not show it properly. We'll show you in the video. So and then the 5 when it is retracted further. So we'll show you how we do it. I will do it depends on the tear itself that dictate how much I need to do, that I will need to do a single row, or if it is a larger tear with a more broad base, I will go for a double row fixation. So this is a tear that's grade 3. You can see here, it's open up. And so we go with the pride. We have to facilitate the subscapularis coming to the lesser tuberosity. And to do that, you need to clear the scarring and from the soft tissue around the subscapularis itself. You have to debride behind it, between the subscapularis and the conjoint tendon, and you have to debride the footprint area. I use a suture to pull the tissue, so I go through the anterior portal, so to pull, to open up the space here, so I can debride the footprint with the acromionizer to freshen up the bone edges for healing. And then in this case, I did a couple of suture anchors, knotless. The bone quality was good. I was happy with that. And here I'm looking, this patient has also supraspinatus tear, so I use that to visualize as well through it. And that's the 2 anchors here. You can see now, as we external rotate, the tendon is coming with us. So that's for the single row, and then a double row depends on the tear itself. So this is a larger, this is grade 4, a tear where the muscle is retracted further behind, and the tissue, you can see the tissue is a frying tissue. And here I debride behind the subscapularis. You can see we are dissecting gently. I use the radio frequency to probe around the nerves, and you can see that nerve is sitting down there. And you need to protect it. Here, the radio frequency, I use it as a probe. I don't use it as a for radio frequency here. I don't want to burn the nerve, but I can dissect and use it as a blunt dissector. You need to make sure that you analyze here. Again, we go back to fix the footprint area. We put a suture to pull the tendon. So when we pass our suture, we can retract on the muscle itself. Here I prepared the footprint area, exactly the same like what we did before. This is an anchor with the suture and tape, and this is for our medial row fixation. We shuttle the suture through the subscapularis, and then it will be again management, and the anterior portal. Second anchor was done superiorly to have a broad base. Then we pass the on the top, and I use it as a single row just to anchor the superior part of the subscapularis. I didn't do that anymore. I changed it, but this is the base of the 2 anchors coming back. This is again. So that's the technique for both. Outcome, arthroscopic repair single row technique results in significant clinical improvement and enduring tendon integrity, although subscapularis strength remain reduced from the normal side. Double row might be stronger, the debate is there. Depends on the size of the tear. I decide my repair. If it's a 3 and more, I go with double row fixation. If it's 1 or 2, I will be with a single row. Thank you.
Thank you, Saeed, for this presentation. Thank you. It's very clear. I would call Dr. Ahmed Saeed now. Dr. Ahmed, are you ready to share your screen? It's okay.
I will go very rapidly, Dr. Osama. I will go very rapidly to not to lengthen the time. As all of we know, with getting age, more in age, the percentage of rotator cuff is increasing at 70 to 79 years old. The working place for the rotator cuff is a subacromial space. Almost we can repair the rotator from the subacromial space. I will go through this. I am interested. This is a nice photograph of a female patient. This is a photograph of a female patient, 56 years old. After cupping, she had a severe shoulder pain, repeated cupping, and MRI solves the problem. After ultrasound, 36 setting of ultrasound for shoulder pain, he had a skin burn. This is his arthroscopic view of a rotator cuff tear. This is the problems of diagnosis of rotator. The point of 2-point fixation or double row fixation for rotator cuff depends on inserted to a single point in the bone of the gratefus, about 18 to 24 millimeter after Burkhardt first. The idea of double row fixation is to enlarge the point of attachment between the surface of the tendon and surface of the bone. Okay. This is an example of articular side tear, partial rotator cuff tear from the articular side, distal lesion. Another example of rotator cuff tear. This is another example of an isolated dorsal side tear. The articular side is intact, while the dorsal side is torn. Let's go for our الفول سيكنس. طبعا diagnosis بتاع rotator cuff بيعتمد على البين والديفيكالت movement, stiffness and weakness. To go for surgery or not, it depends on the patient age. As long as the patient is active or dynamic, we should go for surgery all the time. This is an example of a female patient, 54 years old. Another patient after 36 sitting of physiotherapy, we had a massive rotator cuff tear. The idea of double row repair depends on the footprint. What is a footprint? It's a surface area of insertion. The rotator cuff are inserted not to a 4 millimeter in size for the tendon, supraspinalis or infraspinalis. Next. The idea of repair double row two medial anchors, two lateral anchors to increase the contact surface between the tendon and the bone. This is an articular side tear. This is from outside, the dorsal side is intact. From inside, the articular side, distal lesion is torn. This is an example of dorsal side tear. It's a partial thickness rotator cuff tear, but is not complete to the articular side. This is a full thickness rotator cuff tear from the dorsal to the articular side tear. This is preparation of the rotator cuff bed from the articular side of the head to the last point of the greater tuberosity, using the radio frequency and the bear to get a bleeding surface of bone. Bleeding surface bone is, for me, is an essential. The debridement of the undersurface of the tendon with the shaver is a mandatory for me to get a bleeding surface from the tendon to oppose the bleeding surface of the bone. To do subacromial decompression or not, all the cases of rotator cuff repair, for me, I should go for subacromial decompression before a repair. Using suture anchors, first row, and passing the sutures as usual. Reducing the tear and putting second row. This technique is called the suture bridge technique, using a metal anchor in the medial side, and this second one. I'd like to use this metal because for me it is less to form a foreign body reaction or a cyst in the bone. After doing the medial side repair or the medial anchors application to the greater tuberosity, sutures are done, second row on the lateral surface of the humerus using the bush look technique. This is what we call suture bridge technique. Look for the reduction of the tendon over the bone with advancement of the rapid lock. This is the idea of double row fixation in a beachy chair position. I don't use cannulas usually at this technique, doing this technique. A hypotensive anesthesia is mandatory for me. It allows double row fixation, allows us for rapid movement of our patient, rapid rehab, accelerated, aggressive rehab is my protocol in post-operative for my patients. And as you see, the subacromial space was debrided first, and the movement. Next, please. This is an example of a massive rotator cuff tear. First of all, you should identify your tear edges. Second, debridement, release, debridement of the tendon, release. The tear was to the superior glenoid notch, release with with the radio frequency of the edges of the tendon, trial of reduction, be sure that the tendon can be reduced to the anatomical position you want. In this case, we can get anatomical reduction without too much tension. So we can go for double row fixation for this patient. And the MRI pre is presented, MRI post is presented after 3 months. The healing was ideal. I'm sorry for the difficulty of the net, but the fifth settlement, you know, the net problem and the mobile problems. Again, suture bridge technique, reduction of the tendon to the last point of the greater tuberosity after putting the metal anchor and using the push lock to augment our repair and to allow for rapid movement of our patients. And this is our range of motion after 6 weeks. Okay, thank you. This is my presentation. I'm sorry for the interruption, and I am ready for any questions.
Thank you so much, Dr. Ahmed. Thank you for the nice presentation. I will move on to our last speaker tonight, Dr. Ahmed Hany. Ahmed will show us how he's doing the acromioplasty and AC joint resection.
Good afternoon, everyone. It's a pleasure to be here. I'll be talking tonight about arthroscopic acromioplasty and distal clavicle resection. My presentation is mainly technical, as requested by my dear friend Osama. I will not be going into theory a lot. So as we all know, the classic classification of the types of acromion that we've all been taught in orthopedics, the Bigliani classification. Well, this classification isn't really peer-reviewed. I don't think it's actually there. There's been a lot of criticism. What we believe today is that there are more osteophytes than actual hooking of the acromion. So I don't think a lot of us use this classification nowadays. What we've been talking a lot about recently is critical shoulder angle, which Dr. Jean-David has been talking about earlier. This is basically the angle on the preoperative X-rays of the shoulder. It's the angle alpha between a line between the superior and inferior border of the glenoid, and another line between the inferior angle of the glenoid and the lateral edge of the acromion on an AP radiograph. If this angle is more than 35 degrees, then these patients are more prone to re-tears of the cuff if the lateral acromion is not resected. So this is what we call recently the critical shoulder angle that should be measured preoperatively. How much do we need to resect of the acromion? Once again, a lot of my dear fellows have been talking about it in the past slides. We don't need to resect a lot. As you can see in this diagram, the coracoid ligament in dark blue, a lot of it is coming from, originating from the undersurface of the anterolateral acromion. So in order to remove any spurring and resect this part, you probably need to remove most of the coracoid ligament during the procedure. So this is the first step. You need to resect the coracoid ligament. How much of the bone should you resect? You don't need to resect a lot. The more you resect, the more you will affect the deltoid. So usually just need to smoothen up the surface, remove any osteophytes, just a few millimeters, maybe 3 or 4 millimeters is more than enough. What we need to remove is usually the spurs, any osteophytes that occur underneath the coracoid ligament. These are what we are aiming for in surgery, as well as reducing the critical shoulder angle if it's greater than 35 degrees. So it's an anterolateral acromioplasty, basically. How I do it is basically the patient in what I call a sitting position, not a beach chair position. Junior surgeons should learn how to draw the shoulder and mark it preoperatively. We usually put our marks on the outer edge of the bone. I start by marking posteriorly over the spine, then laterally, then anteriorly, and connect them together. This is very important. When you need to feel your AC joint, mark it as well, and then draw the anterior and posterior borders of the clavicle. In doing subacromial surgery, you want your posterior portal not to be too low, as we'd use in glenohumeral surgery. You want it to be high, so that you're riding over the cuff. That will make your life much easier. And your your lateral portal, I do it along the posterior edge of the clavicle, and you want it to be about 4 centimeters distal to the lateral edge of the acromion. That will make your working portal much easier in the subacromial space. So these are 2 important tips: a high posterior portal and a low lateral portal. If we're doing it viewing from a posterior portal and working from a lateral portal, this is our acromonizer. It's a basic procedure. You just need to resect any excess bone, smoothen up the surface. This is what we usually need to do from the lateral and anterolateral part. This is the most common technique. Another technique is the cutting block technique, where we're looking from lateral and working from the posterior portal. The radio frequency to clear off any soft tissue, and then you go in with your burr just to smoothen up the acromion. And this is how it should look like at the end. A smooth, flat acromion with no osteophytes. This is what I usually do. So in acromioplasty, this is basic. Remove only the spurs, You want an anterior and lateral portal. You want to, to remove the anterior part and the lateral part. You need to resect the coracoid ligament. And we don't do it usually on its own. This is very important. It's usually it's a very common procedure and almost always overdiagnosed and overdone. Isolated acromioplasty, it's very rarely done nowadays in my practice. It's usually always in association with rotator cuff tears. If it's on its own, patients will usually get better without surgery, proper rehab, plus minus injections. So we'll move on to distal clavicle resection, AC joint arthritis. This is very common with rotator cuff tears. You have to know that not every radiological AC joint arthritis needs to be resected. In most patients with rotator cuff tears, these are older patients where the AC joint is usually always arthritic, but not always symptomatic. How do we know that it's symptomatic? First of all, clinically, AC joint tenderness over the AC joint and cross-arm adduction. Secondly, what I do is if the MRI, there's a high signal intensity inside the AC joint, as you see here, this probably means that there are a lot of stresses in this area and it's probably symptomatic. If there's no AC tenderness and no high signal intensity in the MRI, I usually will not resect the distal clavicle, even if it's arthritic and radiographs. And a lot of recent studies shows that there's no difference doing it or not if the patient is not symptomatic. How do I do it? Once again, sitting position, mark the shoulder, and it's very important that your anterior portal is in line with the AC joint. If it's a bit medial or lateral, the resection will be very difficult. When you're doing this procedure in the first few times, it might be wise to insert a needle once after you drape before you enter the shoulder inside the joint. This needle will help you in locating the AC joint in the subacromial space. I'll emphasize again, you want your anterior portal to be in line with the AC joint so that you get a triangular resection. If it's too lateral or too medial, your resection will be trapezoidal, to be difficult to resect it properly. So this is an important step. How do I reach the AC joint? You move in the subacromial space first along the lateral border, then along the anterior border, along the anterior border until you reach the AC joint. This is the direction where you should move in the subacromial space. Another tip is to push down on the clavicle to be able to visualize it arthroscopically. So this is a short video of how I do it, step by step. It was done with the help of my fellow, Dr. Amr Sami, so I'd like to thank him. This is me looking from the posterior portal, working from the lateral portal, moving along the anterior acromion, resecting all the soft tissue, and now I'm moving medially, looking for my needle and for the joint. Once you're comfortable, you don't need the needle anymore, but in the first few times, it will be helpful. Take your time. Resect all the soft tissues. Do not resect any bones. Look for your needle. You can look for it and you can feel it as well. So there's our needle inside the joint. Now you know that you're there. Push down on the clavicle. As you can see, the clavicle is moving. Now you're sure. You need to resect the inferior capsule of the AC joint. You should keep as much as possible of the posterior and the superior capsule. Where's the joint? As you can see, there's arthritis, significant arthritis. Clear up the distal end of the clavicle so that you can visualize it properly from anterior to posterior. Then put in your acromonizer or burr from the anterior portal. As you can see, it's in line with the joint, which is very important. And start resecting from down up and from anterior to posterior. We usually miss the posterior and the posterior superior part of the distal end of a clavicle. So you should make sure that you get them properly resected. Always ask your assistant to push down on the clavicle while you're resecting. And switch the portals. This is very important. So you can get a 3D view of the distal end of the clavicle so that you're not missing anything. Now I'm looking from the lateral portal, working from anterior. How much do I resect? You need at least 5 millimeters, the thickness of an acromonizer or a little bit more. Make sure that your acromonizer can move freely all the way up, all the way through. One trick I use, I inject usually the AC joint pre-operatively so that I would reduce the bleeding when I'm resecting the bone. This is a nice tip. Now my acromonizer, as you can see, can move all the way through. Then I'll look from anterior portal and make sure the resections are complete. I've got a little bit of remnants superiorly, so I'll have to resect a little bit more. I'll go back, resect what's left. Switch back anteriorly, make sure that you got a good resection of the AC joint. This is the post-operative X-ray. So in summary, important tips when doing AC resection is that your anterior portal has to be in line with the AC joint. You move anteriorly along the anterior edge then medially to reach the joint. Push down on the clavicle to make sure that you're in the right place. You have to see the whole distal edge and do not forget to resect the posterior superior part. And always switch portals to make sure that you got your resection right. Thank you.
Thank you so much, Ahmed, for this very nice presentation, well illustrated. We're done with the presentation for tonight. So guys, thank you very much for your attendance tonight. It was a pleasure to have you on board. Thank you for the EGAA, the Egyptian Arthroscopy Association, to participate with us in this webinar. Thank you, John David, for your time. Thank you, Dr. Ahmed Saeed and Dr. Ahmed Hany from Egypt. Thanks, Dr. Saeed Althani, and hope to see you next week, the same time.